Ladies and gentlemen, I'm Dr. Prosper Tettey Doe, and welcome you to this Notes on Resuscitation, which will cover basic life support as well as automated external defibrillator.
Hospital cardiac arrest and undergo resuscitation by ambulance staff each year, Perkins et al. 2015. The proportion of these people who survive and go home is 7 to 8%. Survival could be 3 times higher should immediate life-saving treatment be administered at the time of onset of cardiac arrest by an appropriately trained bystander. The purpose of this e-learning module is to provide the learner with the theoretical knowledge and a basic understanding of the knowledge behind the techniques used in emergency first aid situations. Additional face-to-face training and assessment should be arranged to assess the learner's competency in the safe and effective delivery of adult basic life support, BLS, and cardiopulmonary resuscitation, CPR. aids. Upon completion of this module, the learner should be able to explain the importance of basic life support, BLS, discuss the differences of cardiac arrest and a heart attack, know how to summon immediate emergency help in accordance with local protocols, start CPR using chest compressions on the unconsciousness adult following cardiac arrest, maintain CPR with the correct ratio of chest compressions to rescue breaths, initiate an appropriate emergency response in accordance with Resuscitation Council, UK, guidelines, place a conscious casualty in the recovery position, treat a casualty who is choking, maintain an open airway, initiate and maintain effective lung ventilations in accordance with the current Resuscitation Council, UK, guidelines, know how an automated external defibrillator, AED, can be operated safely and appropriately. Understand their individual role and responsibilities in responding to persons in emergency situations. Understand their individual responsibilities in reporting and recording details of an emergency event accurately. Understand the importance of undertaking any resuscitation interventions within the limits of their personal capabilities. Introduction to Adult Basic Life Support, BLS. Basic Life Support, BLS, is the administration of emergency care to treat casualties suffering from potentially life-threatening injuries or illnesses until such time they can be provided with full medical care in hospitals. Treatment can be provided by any trained individual who has undertaken an appropriate, accredited BLS course. It is important to advise, however, that individuals are also strongly recommended to undertake face-to-face practical sessions as well as completing this e-learning course. Early intervention can literally be the difference of life and death when an individual collapses and loses consciousness during a cardiac arrest. Recent statistics show that the UK ambulance service responds to approximately 60,000 cases of suspected cardiac arrest, and in less than 50%, approximately 28,000, of these attendances, will ambulance services attempt resuscitation because it is too late. Perkins et al. 2015. Two of the main reasons why resuscitation is not attempted are either the casualty has been dead for several hours, or due to not receiving life-saving treatment by a bystander, that by the time the emergency services arrive, the individual has died. There are a few simple steps that anyone witnessing a cardiac arrest or finding an unconscious casualty can take to help save their life. Calling 999 112, performing CPR, cardiopulmonary resuscitation, and if appropriately trained using a PAD, public access defibrillator, or automated external defibrillators. Many people lack the skills, knowledge or confidence to intervene. However, by providing appropriate training and empowering individuals in such emergencies can double the chances of survival and reduce the mortality rate as it presently stands. The 3 Ps of first aid. The aims of administering first aid and basic life support are to preserve life, Prevent the situation, condition from worsening and promote recovery. Preserve life. Not only the casualty's life, but bystanders and your life. Often, where one person's life is in danger when emergency services are called to the scene of an incident that upon arrival are there more casualties. Priority is to ensure you are safe before you intervene to save another. Prevent the situation/condition from worsening. The role of the first aider/person at the scene is to take appropriate action to remove any environment dangers including oncoming traffic or exposure to dangerous fumes and to prevent the casualty's condition from becoming worse. Promote recovery. The actions of the first aider/person at the scene should, after preventing things from getting worse, help the casualty to recover from their illness or injury until medical personnel take emergency services attend the scene. Back to basics. Anatomy refresher. Organs of the respiratory system. Breathing is a fundamental part of sustaining life. When we breathe, we inhale oxygen and exhale carbon dioxide through a process called gas exchange, which takes place in the respiratory system. The exchange of gas is the body's way of getting oxygen into the bloodstream and to other tissues and organs. Upper respiratory tract, composed of the nose, the pharynx, and the larynx. The organs of the upper respiratory tract are located outside the chest cavity. Nasal cavity, inside the nose. The sticky mucous membrane lining the nasal cavity traps dust particles, and tiny hairs called cilia help move them to the nose to be sneezed or blown out. Sinuses, these air-filled spaces alongside the nose help make the skull lighter. Pharynx. Both food and air pass through the pharynx before reaching their appropriate destinations. The pharynx also plays a role in speech. Larynx. The larynx is essential to human speech. Lower respiratory tract, composed of the trachea, the lungs, and all segments of the bronchial tree, including the alveoli. The organs of the lower respiratory tract are located inside the chest cavity. Trachea, located just below the larynx. The trachea is the main airway to the lungs. Lungs. Together the lungs form one of the body's largest organs. They're responsible for providing oxygen to capillaries and exhaling carbon dioxide. Bronchi. The bronchi branch from the trachea into each lung and create the network of intricate passages that supply the lungs with air. Diaphragm. The diaphragm is the main respiratory muscle that contracts and relaxes to allow air into the lungs. The heart. The heart is the hardest working muscle in the human body. It is a sophisticated pump that is controlled by an electrical current controlled by the brain and is located almost in the center of the chest. In adults, the human heart is about the size of a clenched fist. The average rate that a heart beats is 80 times per minute, which equates to around 115,000 times in one day or about 42 million times in a year. In a 70-year lifespan, the average human heart will beat more than 2.5 billion times. Even when a person is at rest, the heart continuously works hard. The heart is made up of 4 chambers, left and right atrium and left and right ventricle. The right atrium receives oxygen poor blood from the body and pumps it through the tricuspid valve to the right ventricle. The right ventricle pumps the oxygen poor blood through the pulmonary valve to the lungs. The left atrium receives oxygen-rich blood from the lungs and pumps it through the mitral valve to the left ventricle. The left ventricle pumps the oxygen-rich blood through the aortic valve out to the rest of the body. Cardiac arrest or heart attack. Cardiac arrests are life-threatening events where the heart suddenly stops beating and the blood supply to the brain fails. Problems with the heart's electrical system can cause irregular heartbeats called arrhythmias. During an arrhythmia, the heart can beat too fast, too slow, or with an irregular rhythm. Some arrhythmias can cause the heart to stop pumping blood to the body, subsequently causing sudden cardiac arrest. People who have heart disease are at higher risk of cardiac arrest. Other problems with the heart's electrical system can also cause cardiac arrest. It is important to highlight that a cardiac arrest can happen to any individual regardless of age, gender, race, etc. However, in most cases there are indicators where inherited disorders, familial history, physical stressors, drug or alcohol abuse, major blood loss, trauma or structural changes in the heart that can increase the incidence of such cardiac events. During a heart attack, the heart usually doesn't suddenly stop beating. However, cardiac arrest may happen after or during the recovery from a heart attack. Heart attacks are normally caused by physiological changes in the heart muscle, such as build of fatty deposits that occlude or narrow the blood supply to the heart muscle. If the blockage or narrowing occurs in the coronary artery and restricts the blood supply of oxygen-rich blood to your heart, this is a heart attack. BHF 2015. Heart muscle cells die and are replaced with scar tissue. The scar tissue damages the heart's electrical system, disrupting the electrical signals and spreading them abnormally or erratically throughout the heart's tissue. These changes to the heart increase the risk of dangerous arrhythmias and sudden cardiac arrest. Cardiac arrest. In some instances, an irregular arrhythmia known as ventricular fibrillation, VF, can cause the heart to go into spasm and stop beating. This is known as sudden cardiac arrest. Signs and symptoms suggesting a person has gone into cardiac arrest include: they appear not to be breathing. They are not moving. They do not respond to any stimulation, such as yellow pinch, sternum rub, or when spoken to. If you think somebody has gone into cardiac arrest and you do not have access to a piece of equipment called an automated external defibrillator, AED, you should perform chest compressions to circulate blood to the brain. Otherwise, commence and follow the chain of survival. Heart attack. Chest pain, a sensation of pressure, tightness or squeezing in the center of your chest. Pain in other parts of the body. The pain is traveling from your chest to your arms, usually radiating into the left arm, but can affect both arms, jaw, neck, back and abdomen. Feeling lightheaded or dizzy. Sweating, clammy to touch. Shortness of breath. Feeling sick, nausea, or being sick, vomiting. An overwhelming sense of anxiety, such as a panic attack. Competency. Chain of survival. The chain of survival describes the 4 key interlinked steps, which, if delivered effectively and in sequence, optimizes survival from out of hospital, and in healthcare settings, cardiac arrests. The process of implementing the chain of survival has been derived from the recommendations and guidelines issued by the Resuscitation Council, UK, 2015 for delivering basic life support in adults. Link 1. Early recognition. Early recognition to the emergency response system, including the recognition of the cardiac event and early notification of rescue teams by calling 112 from mobiles and 999. Link 2. Early CPR. The actions of the rescuer, bystander performed in a set sequence to assess and support airway, breathing and circulation until such time emergency response team arrive at the scene. Link 3. Early defibrillation. The delivery of shock by a qualified bystander, rescue device/pad, if available, to convert VF arrhythmias back to normal rhythm, sinus rhythm. Link 4. Early advanced care, relates to the response of advanced medical personnel such as paramedics who can respond to the casualty and have provisions in place to administer life-saving drugs and secure airways until such time they are transferred to the nearest emergency center. Chain of survival diagram. Cardiopulmonary resuscitation, CPR. The Dr. ABC action plan is the simplest way to ensure the effective assessment of any casualty before considering and implementing CPR, and in the following sequence. D. Check for danger and don't panic. R. Check for response. A. Assess and open airway. B. Check and feel for breaths. C. Check the pulse circulation. Danger risks to the rescuer. Ensure that the casualty, any bystanders and you are safe before considering intervening and assist. Moving and handling risks. Beware of environmental dangers such as exposure to gas, fire, fuel spillage, traffic, etc. Response. Check the casualty for response. Gently shake or tap the casualty's shoulders and ask, "Are you all right? Can you hear me?" Should the casualty respond, leave them in the position you found them in and try to find out what happened. Call for help and reassess regularly. In the case of the casualty not responding to verbal or physical stimuli, shout for help immediately, but do not leave the casualty unattended. Causes of unconsciousness. In the event your casualty is unconscious, immediate action and priority is to ensure that the airway is patent and to protect it from blockage or obstruction and call for emergency help. There are many causes of unconsciousness, and a useful way to remember is using the acronym is-shaped. F. Fainting. I. Imbalance of heat. S. Shock. H. Head trauma, injury. S. Stroke. H. Heart attack. A. Asphyxia, choking. P. Poisoning. E. Epilepsy. D. Diabetes mellitus. Levels of response. To measure a casualty's level of consciousness, a useful assessment tool to utilize is the APRA scale. Alert, the casualty is fully awake although may be disorientated. Eyes open spontaneously. Voice, casualty can make some form of acknowledgement when you talk to them. Pain, casualty makes a response on any of the following three components on the application of pain stimulus: sternum rub, jaw margin clench or pinching at earlobe. Unresponsive, casualty gives no evidence of response to any of the stimuli. If the casualty does not respond, the next stages of the algorithm in linear sequence is the assessment of airway, breathing and circulation. Airway. Carefully open the airway by using the head tilt and chin lift. Place palm of hand on forehead, tilt the head back and simultaneously place 2 fingers on the chin and lift the chin to open the airway. Check the casualty's mouth and remove any visible obstruction. Recheck that there is adequate head tilt and chin lift. Assess for sign of breathing. Breathing. Keeping the airway open, look, listen and feel for breathing. No more than 10 seconds should be taken to do this. Look for chest movement. Listen at the casualty's mouth for breath sounds. Feel for air on your cheek. Look, listen and feel for approximately 10 seconds to determine if the casualty is breathing normally. Should you have any doubt as to whether breathing is normal, act as if it is not normal. Caution: in the first few minutes after cardiac arrest, a casualty may be barely breathing, or taking in frequent, noisy gasps. These are known as agonal gasps and should not be confused with normal breathing. If in doubt, commence CPR. Circulation. If the casualty is not breathing normally, call for help, and if you have undertaken appropriate training, ask a bystander to bring a defibrillator, AED, if available. If you are alone, call for help and only leave the casualty if there is no other way of obtaining help. Chest compressions only. Kneel at the side of the casualty and start chest compressions as follows. 1. Chest compressions are normally delivered by a single ladder. Situate yourself next to the casualty and in kneeling positioning. 2. Place the heel of your hand in the center of the chest, lower half of the sternum, with the heel of the other hand on top, interlocking fingers as in below image. Ensure no external pressure can be applied to the casualty's ribs, to avoid risk of puncture to lung or rib fracture. 3. Position yourself vertically above the casualty's chest, straighten arms and press downwards approximately 5 to 6 centimeters. The Resuscitation Council, UK, advised that a compression depth range of 4.5 to 5.5 centimeters in adults needs better outcomes than all other compression depths during manual CPR, and to aim for 5 centimeters but no more than 6 centimeters in an average size adult. 4. Do 30 chest compressions at a rate of 100 to 120 minutes superscript 1, 100-120 per minute. 5. After each compression, release all the pressure on the chest wall without losing contact between your fingers and the sternum. 6. Compression and release should take equal time and pauses in chest compressions should be minimal. 7. CPR provider fatigue can cause inadequate, insufficient technique, and where possible, CPR providers should alternate every 2 minutes to prevent a decrease in compression quality and promote increased chance of effectiveness. Combine chest compressions with rescue breaths. CPR providers should give rescue breaths with an inflation duration of 1 second and provide sufficient volume to make the casualty's chest rise. The maximum interruption from chest compressions to providing rescue breaths should not exceed 10 seconds. Resuscitation Council UK, 2015. Open the airway as previously discussed using the head tilt and chin lift. Pinch the casualty's nose to close nostrils, allowing the mouth to open, but maintaining chin lift. Take a normal breath and seal your lips around the outside of the casualty's mouth, preferably with a CPR barrier mask if available, creating an airtight seal. Blow steadily into the casualty's mouth, checking for the chest to rise. Rescue breath. Give the casualty 2 full rescue breaths, 1 second each, taking your lips off the casualty's mouth to inhale between each breath. Check for chest rising and falling with each breath you give. The rising of the chest during your exhalations indicates the effectiveness of your breaths. Return your hands immediately to the chest after delivering the second breath and give another 30 chest compressions. Perform 5 sets of the 32 cycles within 2 minutes. Please note, CPR cycles should not be interrupted until a full cycle has been completed or where the casualty is showing signs of consciousness such as coughing, opening their eyes, starting to speak, etc. Continue cardiopulmonary resuscitation, CPR, until an automated external defibrillator, AED, is available. You become exhausted. Emergency services arrive on scene, or the casualty shows signs of regaining consciousness and starts to breathe independently. Automated external defibrillator, AED, and public access defibrillator, BAD. The use of automated external defibrillators, AED, is shown to save lives of patients. 79% of those who received early defibrillation in one study were discharged home, and where 40% of those who survived a cardiac arrest had no evidence of any neurological deficits. Bunch et al. 2003. Public access defibrillators are readily available in busy public places such as train stations, shopping centers, and airports, and anyone can use them in the event of an emergency. You shouldn't be afraid of using a defibrillator if someone has had a cardiac arrest. A defibrillator is a device that gives a high-energy electric shock to the heart through the chest wall to someone who is in cardiac arrest. There are 2 main types of available. Automatic, where the device will automatically shock without intervention from the operator, and semi-automatic, which indicates when a shock is needed, which is then activated by the operator. How to operate. If you come across someone who is not breathing or breathing erratically, your priority is to call the emergency services on 112/999 and then start CPR to keep the blood flowing around the body. After a cardiac arrest, every minute without CPR and defibrillation reduces someone's chance of survival by 10%. If you're on your own, don't interrupt the CPR to go and get a defibrillator. When you call 999, the operator can tell you if there's a public access defibrillator nearby. As soon as a passerby is near, ask them to get that /pad. Continue manual CPR 30 to 2 until such time that /pad is attached. Once the defibrillator is open and in position, all that is required is to follow the spoken instructions. Many defibrillators will also have diagrams or a screen to help you. The defibrillator detects the heart's rhythm and will not deliver or advise of a shock unless it is clinically required. You should resume CPR as soon as instructed by the defibrillator. Summary. Resuscitation Council, 2015. Unresponsive. Shout for help. Open airway. Not breathing normally. Circumstances in which those decisions would apply. An advanced decision can only be considered if the individual is aged 18 or over and had the capacity to make, understand and communicate their decision when they made it. They specify clearly which treatments they wish to refuse. They have clearly explained the circumstances in which they wish to refuse them. It is signed by the individual under the presence of a witness should they want to refuse life-sustaining treatment. They have made the advanced decision of their own accord, without any harassment or influence by anyone else. They haven't said or done anything that would contradict the advance decision since it was made. For example, saying that you have changed your mind. Where a properly drawn-up ADRT refuses CPR, despite acknowledging that their life would be at risk. A healthcare professional WHO attempts CPR on that person in full knowledge that the valid ADRT would be at risk of a charge of battery. Healthcare professionals will be protected from liability if they stop or withhold treatment because they reasonably believe that an advance decision exists, and that it is valid and applicable. Treat a person because, having taken all practical and appropriate steps to find out if the person has made an advance decision to refuse treatment, they do not know or are not satisfied that a valid and applicable advance decision exists. You have a responsibility to know and comply with ADRTs/NAGPRA and should comply with each organization's do not attempt resuscitation policies. A signed record of the order must be available to all concerned with the patient's care. Choking. Choking is an uncommon but potentially avoidable cause of accidental death. Most choking events are caused by or associated with eating, and are commonly witnessed in restaurants, canteens, etc. As victims are initially conscious and responsive, early interventions can be life-saving. Choking can also be triggered in those with reduced consciousness, drug and/or alcohol intoxication, neurological impairment with reduced swallowing and cough reflexes, for example stroke, Parkinson's disease, respiratory disease, mental impairment, dementia, poor dentition and older age. Recognition and immediate intervention of an individual choking due to airway obstruction is paramount to optimize a successful outcome. The easiest way to recognize choking is to ask the casualty, "Are you choking?" Other signs can include: the casualty is unable to speak or cough, grasping or pointing to their throat, distressed, congestion or reddening of the face to skin gradually changing to pale skin and cyanosis, a bluish discoloration of the skin due to poor circulation or inadequate oxygenation of the blood, unconsciousness in later stages. Steps for effective management in the choking adult. The Resuscitation Council, UK, has provided a sequence or steps in the management of an adult casualty choking. 1. Encourage the casualty to cough. If the choking is only mild, this should clear the obstruction and the casualty should be able to speak to you. 2. If cough becomes ineffective, give up to 5 back blows as follows. Shout for help, but don't leave the casualty unattended. Stand to the side and slightly behind the casualty. Support the chest with one hand and lean the casualty well forward so that when the obstructing object is dislodged, it comes out of the mouth rather than further down the airway. Give 5 sharp blows between the shoulder blades with the heel of your other hand. Check between blows and stop as soon as airway is cleared. 3. If the obstruction is still not cleared, stand behind the casualty and put both arms around the upper part of the abdomen. Lean the casualty forwards. Clench your fist and place it between the umbilicus, navel, and the rib cage. Grasp your fist with your other hand and pull sharply inwards and upwards. Repeat up to 5 times. If the obstruction is still not relieved, continue alternating 5 back blows with 5 abdominal thrusts. 4. If the obstruction is still not cleared, repeat steps 2 and 3. If the treatment is ineffective, shout for help again and ask someone to call 112-999 for emergency help, but don't interrupt the treatment whilst the casualty is conscious. Assess severity diagram. Assess severity diagram. Record keeping and reporting of out-of-hospital cardiac arrests. Accident logbooks/incident forms are essential on the ongoing, systematic collection and analysis of data about out-of-hospital cardiac arrest and bystander CPR. The Out-of-Hospital Cardiac Arrest Outcomes (OCOW) registry provides a tool to support local quality improvement, and whilst participation in the registry is voluntary, it is strongly endorsed by the National Ambulance Service Medical Directors Group. The Emergency Event Report is designed to enable the first aider to keep a record of events and actions taken leading up to when the casualty's care is transferred over to the emergency services. Information that should be recorded include the date, time, and place of the incident. If known, the age, name, and any medical information the casualty may have on their possession. Details of the injury, illness, and what first aid was given. What happened to the casualty immediately afterwards. The name and signature of the first aider or person dealing with the incident. Things to be aware of. It is your responsibility to ensure that you retain a record of what happened, actions taken, and details of the treatment provided on the scene. Records must be clear and accurate. Records must be written in permanent ink. Do not make changes to notes once they have been written. Make sure notes are legible. You should always adhere to your own organization's protocols for recording an emergency incident. References.